and thank you once again for the invitation to give a presentation at this symposium about economics and healthcare in atopic dermatitis. The presentation starts with an introduction to health economics, and then I'd like to show you the current status of health economic analysis in atopic dermatitis. First of all, why should we be interested in this issue? Why should you be interested? As we do know, at least from the presentations before me, atopic dermatitis affects a large number of children and adults and is strongly associated to several comorbidities, including atopic manifestations like asthma, allergic rhinitis, and food allergy. So this was also shown in a study by Su et al. Here they concluded that patients with atopic dermatitis are significantly more likely to develop atopic manifestations compared with patients without AD. And furthermore, the incremental cost attributable to atopic manifestations in patients with atopic dermatitis. And those were the costs in patients with atopic dermatitis without the development or before the development of atopic manifestations, and these were the costs after the development of atopic manifestations. So the incremental costs for atopic manifestations were highest due to asthma, followed by allergic rhinitis. The third point why we should be interested in this issue is that atopic dermatitis is accompanied by a high disease burden and impairments in health-related quality of life. Using, for example, the Children's Dermatology Life Quality Index in children between 5 and 16 years old, it was found that psoriasis and generalized eczema, here meant as a generalized atopic dermatitis, caused the highest impairments in health-related quality of life, followed by urticaria and acne. Using the Children's Life Quality Index, in the parents of these children, there occurred also the highest score for generalized atopic dermatitis, followed by urticaria and psoriasis. There were also comparisons undertaken in adults. For example, Weikert et al. Used the Dermatology Life Quality Index, and he found that the percentage of patients with moderate to very severe impairments in health-related quality of life is the highest in patients with atopic dermatitis compared to other chronic skin diseases. In the same study, they estimated the determinants that predict quality of life in patients with atopic dermatitis. Those were, for example, skin dryness, sleep disturbances, and affected body surface. But in health economics, we are rarely solely concentrating on the quality of life, but rather on the determination of quality-adjusted life years. So, for example, here it was found out that the cost-effectiveness ratios for Elidel, known as pimecrolimus, were consistently below $50,000 per QALY gained. So what is meant by this result? What is meant by QALYs? For those who don't know, let's take a short look at this slide. QALYs, quality-adjusted life years, taking into account both how long you're going to live and the quality of life. Length of life is typically measured in years, and quality of life on a scale from 1 to 0. 1 is equivalent to perfect health and 0 to death. So if we are having a length of life of 10 years with the quality of life of 1, then this would give 10 times 1, which is equal to 10 QALYs. If we are having 20 years in with a quality of life of 0.5, this would give 20 times 0.5, which is also equal to 10 QALYs. So assuming we are having an existing treatment, and with the existing treatment, the quality of life and length of life can be displayed on this curve. And this is equivalent to 19 QALYs. So with the new treatment, there can be an improvement in quality of life like this. So we have a QALY gain by the new treatment of 5. So the incremental benefit for the new treatment is 5 QALYs, for example, and the cost for the new treatment, 150,000 euro. Then our incremental cost utility ratio or our cost effectiveness ratio is 30,000 per 1 QALY. Of course, in economics, we are not only interested in quality-adjusted life years or quality of life, but also in the monetary cost of a disease. So with the aim of calculating the economic burden of a disease, we are choosing a cost of illness study. Which cost data do we need here? We distinguish between direct costs, indirect costs, and intangible costs. Direct costs are due to provider appointments, for example, or hospitalization and medications. And indirect costs are due to or include financial losses due to missed work and decreased work productivity. And intangible costs are directly related to the impairments in quality of life. Direct costs occur for insurance payers and patients, indirect costs for society, and intangible costs for the patient. There were several studies undertaken to characterize the economic burden of atopic dermatitis, and one of the most far-reaching economic evaluations was done in 2004 in the US. Here, they estimate that the direct costs, indirect costs, and intangible costs for 22 skin diseases, and the prevalence for atopic dermatitis was estimated to be over 15 million in 2004 in the US, and this resulted in a total burden of $4 billion for atopic dermatitis. For example, in psoriasis, the burden was estimated to be lower. Focusing on the indirect cost in this study, then we can see that among the non-life-threatening skin diseases, atopic dermatitis had the highest indirect costs, and this was especially due to caregiver lost work days, which were highest in atopic dermatitis among all these 22 skin diseases. So we are looking at the cost of a disease, or we are looking at the cost of treatments, and when we are taking the benefit into account as well, then we are talking about a full economic evaluation. So when we are comparing a new treatment with the existing treatment, there are first costs, and the benefit of the new treatment have to balance these costs. And we can find out if there's a balance between costs and benefit with a cost-benefit analysis, for example. Here we are measuring the benefit in monetary terms. When we are looking at the difference in symptoms, so we are looking at a decrease in itching or decrease in pain between the two treatments, then we are doing a cost-effectiveness analysis. And when we are concentrating on quality-adjusted life years that can be gained by the new treatment, then we are doing a cost-utility analysis. And this is kind of a cost-effectiveness analysis. Cost-effectiveness or cost-utility analysis are often visualized on a plane consisting of these four quadrants. So on the vertical axis are the costs, and on the horizontal axis, the effects. So assuming there's treatment A or standard care and a new treatment B with additional costs and additional effect, our key outcome is here the incremental cost-effectiveness ratio. So we are looking at the difference in cost between treatment A and B divided by the difference in effect between treatment A and B, and this is then our cost-effectiveness ratio. So, and effectiveness can be, for example, defined by the number of patients receiving treatment success. If there is another treatment C with a lower cost than B and additional effects than treatment B, then treatment C will be considered as cost-effective, as you need lower costs for more effectiveness. This was the introduction how to understand health economic analysis, and now we wanted to know how often such economic analysis occur in atopic dermatitis. So we did a systematic literature research for previously published health economic analysis in atopic dermatitis, and we searched in PubMed and Embase and used the keywords atopic dermatitis as well as synonymous terms with the combination of cost. And with PubMed, 424 records returned, with Embase 655, and after excluding the conference abstracts and duplicates, then 505 records were screened by the title and abstract, and then by assessing the full text. In the end, 89 analyses were included, which given insights in current health economic research in atopic dermatitis. Focusing on the years and on the settings of the analysis included, then we can see that the interest in health economic research has increased over the years and is most popular in the US, followed by Germany and UK. In German language were 2 articles of the 89 analysis included, by the way. The most analysis targeted children, whereby 13 analyses dealt with the prevention of atopic dermatitis in infants. And only in the half of the analysis included, also indirect costs were included, although we know that indirect costs have a high influence of the total economic burden of atopic dermatitis. This was also recently shown by Frelanowski et al. They estimated the monthly direct and indirect costs of atopic dermatitis, and they found that the percentage of indirect costs on the total cost is 73%. There were several types applied in health economic research in atopic dermatitis, and there were 35 cost of illness studies found. One is from one of our speaker, Drucker et al., and from Schwester et al. Was a recently conducted cost of illness study, and also from Eckert et al. For example, Eckert et al. Used data from the 2013 National Health Awareness Survey. Here, those are patient-reported data based on an internet-based general population survey. Here, it collects also data on healthcare utilization, and in 2013, 75,000 adults met the inclusion criteria. So Eckert et al. Looked here for the annual per patient direct costs in adults, and the analysis cohort comprised 349 patients with atopic dermatitis, and those were matched with 698 patients without atopic dermatitis concerning sociodemographic data and so on. So they were looking at the risk for comorbidities in patients with atopic dermatitis and without atopic dermatitis, and they found that the risk is higher in patients with atopic dermatitis. And also the healthcare use were higher in the ED cohort versus the non-ED cohort in terms of healthcare provider visits, hospitalization, and emergency room visits in the past 6 months. And this difference between the ED cohort and non-ED cohort resulted to around 8,000 per patient and year, which were estimated, which will be the costs for it attributable due to atopic dermatitis. Here I want to show you that I like to compare the results of Eckert et al. With recently conducted results of Drucker and Schwester et al. And here they all had the same research question, a similar data year, and they, Eckert et al. Used patient-reported data, Drucker and Schwester et al. Used claims databases, and they all were looking at the course in patients with AD compared to patients with matched patients with non-AD. And the difference were a bit different here. So I just wanted to show you by this that even if you have the same research question and the similar data year, costs may occur due to different methods and different populations. Eckert et al. Also found out that higher disease severity is associated with higher economic burden. This was also found by other authors. And here the differences in the percentages of how higher the costs are in the severity population, in the severe population, here the differences might not be just occur due to the different methods, data setting and so on, but also due to the difference in determination of severity. So in Eckert et al., the patients were just asked, how severe is your disease, from mild to severe? And in Drucker, here in the claims databases, it depended on the treatments that were described. And when you are using other databases, you can look at assessment scores of severity. In general, not only in health economics, but in general, we do know that it's difficult to make cutoffs between severity. And so it's also difficult to compare those analyses. And then I like to focus on the full economic evaluations that were included. Those 26 concerned the treatment of atopic dermatitis. Several analyses were did here, and the target setting was mostly Europe. Most analyses targeted children, 9 analyses the adults, and 7 analyses both populations. And also here, only in the half of the articles, also indirect costs were considered. Concerning the effectiveness parameters to evaluate or estimate the cost-effectiveness ratio between treatments, authors predominantly calculated the cost per QALY. Otherwise, however, very different effectiveness parameters were used here. Many different treatments were compared in health economic analysis, mostly tacrolimus and pimecrolimus. They were partly compared with each other and partly with standard treatment like corticosteroids. And here is an example, one of the earliest examples of a comparison between tacrolimus and pimecrolimus. Here, Abramowitz et al. Estimated in children the cost per disease-controlled days. And a disease-controlled day was defined as a day on which patients did not require any topical prescription therapy. So it was found that tacrolimus resulted in lower costs, or the use of tacrolimus resulted in lower costs, and tacrolimus showed more disease-controlled days. So the cost-effectiveness ratio was lower for tacrolimus, which means that tacrolimus was considered more cost-effective than pimecrolimus. So you need lower costs per 1 DCD. Also, Tania et al. Made such a comparison, but in adults, and they estimated the cost per additional day with resolved AD, and a day with resolved AD was meant to be a day where the patient has an investigated global atopic dermatitis assessment score of clear or almost clear. So patients receiving tacrolimus had again more days with resolved AD and lower costs. So tacrolimus was again estimated to be cost-effective compared to pimecrolimus. And Tania et al. Did some sensitivity analysis. So here you can see that even if many different assumptions were made, tacrolimus was still more effective and less expensive than pimecrolimus. Then I'd like to show you a more recent full economic evaluation in dupilumab. Here, Gutknecht et al. Searched for the cost per QALY in adults in the US population, and they found that dupilumab led to lower costs compared to supportive care of $32,000 and to higher QALYs of 1.12. Here, the price of dupilumab was not yet considered in this difference of costs. Instead, the authors were interested how high the price of dupilumab can be to be still considered cost-effective. So assuming you are willing to pay $100,000 per QALY gain, then dupilumab have to be under $29,000 per year. Or if you are willing to pay $150,000 per QALY gain, then dupilumab have to be around $40,000 per year. And a most recently conducted evaluation was done by Zimmermann et al. They also estimated the cost effectiveness of dupilumab by cost per QALY in adults. And here the annual price list for dupilumab was considered to calculate the cost effectiveness ratio. And it was found that in the base case population, a mix from the moderate and severe population, that 1 QALY would cost $125,000, and when we are looking at the cost effectiveness in the moderate population, then to gain 1 QALY would cost $160,000, and in the severe population, the cost utility was lower, so $96,000 per QALY. So it was estimated by Zimmermann et al. That the cost effectiveness of dupilumab is in the severe population the highest. So here I just wanted to show you the different prices in treatments of atopic dermatitis. And I like to repeat that in health economics, it's not just comparing apples with oranges when we are looking at the cost. So we are looking at the cost, but we need to consider the treatment benefit, and the treatment benefit has to balance those costs. So I like to summarize that atopic dermatitis is a common disease of increasing prevalence and can cause significant morbidity. Impairments in health-related quality of life have been shown to be higher compared to other chronic skin diseases. And cost of illness studies proved the high economic burden of atopic dermatitis. There is especially burden due to indirect costs. And based on recent data from 2013 in the US, the cost for atopic dermatitis range between $3,000 and $9,000 per patient per year. And the economic impact of atopic dermatitis is directly related to the severity of the disease. Given the different healthcare environments and databases chosen, we can see marked differences in the cost of illness, and there's also a variety of methods due to several research questions. So in atopic dermatitis, you are also interested in the prevention. And in comparisons of treatments, there were several outcomes used to estimate the cost-effectiveness ratios between treatments. And tacrolimus and pimecrolimus was mostly used, whereby tacrolimus was evaluated as more cost-effective. And first studies have evaluated the cost-effectiveness of dupilumab compared to standard care. And here it was shown that in severe population, dupilumab is more cost-effective. For future health economic research, we like to recommend that indirect costs should not be underestimated, and that health economic studies need to be more comparable. So there's a need for standards on methods and outcomes, and also on the determination on severity. And when we are using secondary data like claims data, then we have the bias that the resource used and the cost between AD and non-AD patients may not be just directly attributable due to atopic dermatitis. Real-world data may help to get the excess costs, but there is attention due to recall bias. And in my last sentence, I like to conclude that the total economic burden of atopic dermatitis has to include the impact of comorbidities, as this was shown by the several talks before me. Thank you very much.